was described in the 50s and studied in the 60s. I'm talking of the preceding century. It has not been introduced into clinical practice. One of the reasons is that a lot of, not a lot, but a few very smart, very bright physiologists started to fight about details about the technique, which killed the technique. I think this technique is worth using in clinical practice, and I will try to convince you that it's a very reliable measurement, and I hope we will not go into the same fights again. So these are my conflicts of interest, including the fact that I'm leading the pleural pressure working group called the PLUG. So, and this working group has published a series of papers trying to explain the rationale for using the esophageal pressure, which was very nicely described by Antonio a few minutes ago. You want to know what's the pressure distending the lung, and you want to know what's the influence of the chest wall on the pressure you see on the ventilator. So the esophageal pressure is a technique which measures the pressure in the chest, and I think it makes a lot of sense for us clinicians treating patients with acute respiratory failure to understand what is this pressure. This is the kind of tracings you can obtain. We published this paper in the Blue Journal a few weeks ago, and these are the measurements we do routinely in our ICU. You have the two first curves, which are those displayed on the ventilator screen, the flow and the airway pressure. The third curve is the esophageal pressure obtained at the bedside with a very simple esophageal catheter. And the fourth curve is the difference between airway minus esophagus pressure, which is called PL, L for the lung. It's a transpulmonary pressure, which is directly displayed on the ventilator. Maybe if you just compare the second and the third curve, the airway and the esophageal pressure, you notice that the change, the swings, if you wish, of airway pressure are of much larger amplitude than the swing in esophageal pressure. And this is because the swing in airway pressure reflects the pressure generated to move both the lung and the chest wall, whereas the amplitude of the esophageal pressure only reflects the part due to the chest wall. So this is the basis of subtracting the part due to the chest wall to get an idea of what's distending the lung. The question which is often raised is, what does this pressure exactly measure? And the response is simple: it measures the pressure in the esophagus. Okay? What does it mean? It means the esophagus is in the chest, but it has a location in the chest. And this location, as you can see, is approximately mid-chest, maybe a little bit down. It depends exactly where you are in the chest. And the very important point, which matters a lot for mechanical ventilation, is that the pleural pressure is not one pressure. There is a gradient, as described by Antonio, which goes from the non-dependent part, so this part of the lung, which is probably the part of the lung which is the more at risk of hyperinflation, right? So this is where is the lower pleural pressure, to the dependent part, and this is where is the highest values of pleural pressure. So there is a clear gradient, so the esophageal pressure is just one pressure. It cannot give you the whole gradient. It gives the pressure where it is located. And to be really sure of that, we did a study which is a really large collaborative study. Some part of the measurements have been done in animals, other have been done in cadavers, other have been done in patients with CT scans. Some studies have been done in Sao Paulo, Brazil, some have been done in Toronto, some have been done in Quebec. So we put all our efforts together to try to definitely answer what are we measuring with the esophageal pressure. And so these are data from pigs with normal lung, with injured lung, and also these are data measured in human cadavers. It's a special preparation of the cadavers, so they keep their elasticity, but we thought it was important to also measure pleural pressure in human bodies because the shape of the chest wall and the body is not the same, of course, that in animals, even if we take large animals like with pigs. And this slide is just to show that there is a gradient, which is small in normal lung in pigs, which is larger when you have injured lung, and it's in part related to the weight of the lung. And in human cadavers, it was around 10 to 12 centimeters of water, which is very much in line with what is suspected or measured in human ARDS, for instance. So there is a 10 to 12 centimeters of difference between the dependent part, the highest values, and the non-dependent part. So we say, let's put direct sensors in the dependent part, in the non-dependent part, and let's compare this direct measurement of pleural pressure to the esophageal pressure. And this is here data in pigs, where what is expressed here is the transpulmonary pressure at end expiration. So transpulmonary, you remember, it's airway minus esophageal pressure. And it's calculated using the pleural pressure placed in the dependent part, in the non-dependent part, or in the esophagus. In the pig, you see that the esophagus is very, very far down, very close to the dependent areas. And so it's not surprising that in the pig, the transpulmonary pressure calculated from the esophageal pressure is very close to the dependent values of transpulmonary pressure. So we measure the pressure in the esophagus very close to the pleural pressure in the dependent part. In human cadavers, which we think reflect what happens in our patients, you see that the esophagus has a different location, and because of this different location, the measurements reflect the pressure at mid-chest. So when we have the esophageal pressure, and I'm talking of the absolute value, it reflects the pleural pressure approximately at mid-chest. We had an interesting demonstration of that. We had one of the human cadaver in whom we had those measurements, the same measurement. So this is now the direct absolute value of at n expiration. This is the dependent value, which is very high, the non-dependent value, and the esophageal pressure. You remember that Antonio said, explain why we have pneumothorax if we put a knife in the chest. The pleural pressure gradient explain that you always will have a lower pressure in the pleural space, in the non-dependent part, lower than the airway pressure. So at any value of airway pressure, the non-dependent part will always be lower, so there is always the possibility of pneumothorax. But this also explains that in the dependent part, the pleural pressure is much higher. So we put this cadaver in the prone position, and of course we reversed the measurement. The non-dependent part was now dependent and became the higher pressure. The previously dependent one became the non-dependent and became the lower pressure. And you see that the esophageal pressure, which was a bit closer to this one, remained in between the two. So a nice demonstration of the reliability of the absolute value of esophageal pressure. So when Danny Talmore and his group proposed to keep the lung open by maintaining transpulmonary pressure at end expiration positive as explained by Antonio, it makes sense, but it say we keep the lung open at mid-chest. We don't keep the whole lung open. And maybe this is interesting because at mid-chest, this is where supposedly there is this whole story of opening and collapse. So you try to keep the lung open at mid-chest by maintaining a positive transpulmonary pressure. We don't know whether it's the right way to do, but it has a lot of sense and it has credibility based on this data. However, as we heard from Antonio, some people say, well, we don't believe so much on the absolute value. I think they're wrong for the reason I explained, but they say maybe we should use the ratio of the elastance. Ratio of elastance means, from the first drawing I showed you, the first recording, how much of the airway pressure, the plateau, is simply due to the lung and not due to the chest wall. And this was based on the fact that some patients have a very small part of the chest wall explaining the total elastance. Elastance is like driving pressure, right? It's pressure over volume. And some patients have a much higher contribution of the chest wall. So, for instance, in those patients, if you have a plateau pressure, let's say if this was a plateau pressure of 25, well, the lung plateau pressure would be close to 20, whereas for the same value in those patients, the lung plateau pressure would be 15, much lower. So it's interesting to know that. However, taking the absolute value or taking the ratio, the elastance ratio to calculate the pressure in the lung does not give the same values. And in fact, you have these kind of fights, which I described, between groups saying, we are describing incompatible results, which of course put everyone in a big confusion. I think this simple explanation, and this was already alluded to by Antonio, is that there is not one pleural pressure, there is a gradient. So we saw is the esophageal pressure measure the pressure at mid-chest. What does this ratio measure? The ratio, as told by Antonio, makes the assumption that the pressure, the transpulmonary pressure is close to zero at an expiration, which is not true everywhere, but it's not so wrong if you think to the non-dependent region. And interestingly, when we went back to our data in pigs, we found that calculating the transpulmonary pressure based on the elastance ratio, so not based on the absolute value, based on the elastance ratio, gave a value very close to the non-dependent regions. And same things in cadaver. Not exactly at 1 centimeter of water, but very close. Which is very interesting, because the non-dependent region is the region at higher risk of distension. So we may have the absolute value to titrate peak, because it makes sense, and we may have the calculation based on the elastance ratio to determine the safe threshold for inspiratory pressure. So in conclusion, I think that the esophageal and transpulmonary pressure gives very reliable values of the swings, if you do an occlusion test, give very accurate value of at expiration but at mid-chest, and gives very reasonable assumption of the end expiratory value in the non-dependent lung if you use the elastance ratio. Thank you very much.